Bismillahirrahmanirrahim. Welcome to a new session from a radiology spotter cases, and we will start now. Be ready. Bismillahirrahmanirrahim. Okay, let's discuss the cases. I hope these cases were fine. Okay, first case here, this is a CT brain. We can clearly see there is an areas of encephalomalacias are seen involving the anterior inferior aspect of the frontal lobes. These locations, the anterior inferior aspect of the frontal lobes, are typical for brain contusions. Such location is very important for brain contusion. In old or in chronic cases of brain contusion, we can see the area of contusion transform into area of CSF encephalomalacia. So there is a bilateral rather symmetrical area of encephalomalacia involving the typical location for brain contusion. So this is a typical bilateral frontal brain contusions. Okay, this is the case number 2. Here we can clearly see there is a low occipital occipital defect with a herniation of the cerebellum and the CSF spaces covering CSF spaces here through this defect. This is a low occipital encephalocele is characteristic for type 3 Chiari malformation. We can see the other associated finding seen in Chiari, like enlarged peak tectum, enlarged massa intermedia, hydrocephalic supratentorial hydrocephalic changes with colpocephalic configuration. All these features are matching the criteria of Chiari type 3 malformation. The diagnostic clue here is the low occipital encephalocele that show herniation of the cerebellum and the covering meninges and CSF spaces. Okay, here we can see in this case we can see there is a near total opacification of multiple groups of sinuses, the maxillary sinuses, the frontal, the ethmoidal air cells. These near total opacified sinuses are associated with expansion of the sinuses. The sinuses is expanded and they show dark T2 signal within. These dark T2 signal within are representative or are features of fungal infection, as they are in T1 weighted images. They are intermediate in T1 weighted images, so they are not air loculi. So these features are keeping with allergic fungal sinusitis, multiple sinus involvement. This is number 1. There is near total opacification of the involved sinuses. Number 2, there is an expansion of the bony boundaries of the affected sinuses, and there is an areas of dark T2 signal within the affected sinuses that represent fungal mycetoma or fungal infection. Okay, the case number 4 here, there is a right-sided aortic arch. As we see here, the aortic arch is abutting the right aspect of the trachea. So this is a right-sided aortic arch, and once you diagnose a right-sided aortic arch, you should search for apparent left subclavian artery. If you see an artery crossing the posterior aspect of the trachea, this is an apparent subclavian. In a right-sided aortic arch, this is an apparent left subclavian. In left-sided aortic arch, it will be apparent right subclavian. So in this case, this is a right-sided aortic arch with apparent left subclavian. This artery, as we see, this is the apparent left subclavian here, is showing a dilatation of its origin, which is characteristic of, or which is called of comeral diverticulum. So this is case of a right-sided aortic arch associated with apparent left subclavian artery showing a diverticulum of comeral. In this case, we can clearly see this is an MRI of the whole spine we can see here in the post contrast images there is a uniform enhancement. This is T1 before and this is T1 after contrast injection. We can see a uniform enhancement of the coda equina nerve roots and the leptomeningeal covering of the conus medullaris and distal part of the spinal cord. These features are unique and characteristic of Guillain-Barré syndrome. So this is a Guillain-Barré syndrome which characterized with uniform enhancement of the coda equine nerve roots and the conus medullaris leptomeningeal enhancement. Okay, this case we can clearly see there is a sclerosis, dense sclerosis or sclerotic lesion involving the greater wing of the sphenoid. And as we know, the affection of the greater wing of the sphenoid by a lesion is usually characteristic of meningioma in blood. Meningioma in blood have a very high tendency to affect the greater wing of the sphenoid. So if you see a pathology in a greater wing of the sphenoid, you should think about meningioma in plaque. There is, we can see also there is a extraosseous enhancing soft tissue sheet as here. This enhancing soft tissue sheet is characteristic or associated with a meningioma in plaque and usually help to differentiate such lesion from the other differential diagnosis can occur in the greater wing of the sphenoid, that is fibrous dysplasia. The fibrous dysplasia does not have an extraosseous soft tissue component, so the presence of the extraosseous soft tissue component help to differentiate between both conditions. And also the degree of sclerosis here, this is a sclerosis, not a ground glass. In a fibrous dysplasia, the texture, the bony texture is usually ground glass, not bony sclerosis. Okay, in case number 7 here, this is a CT shoulder. We can see a wedge-shaped fracture involving the anterior medial aspect of the humeral head. This wedge-shaped fracture characteristic of the reverse Hill sac. Case number 8, there is a intensely enhancing hypervascular lesion involving the carotid space region. As we see here, this is a hypervascular lesions showing multiple dilated tortuous hypertrophied arterial feeders with intense enhancement with a characteristic displacement or widening of the carotid bifurcation. This is the external carotid artery and this is the internal carotid artery. This is there is a widening of the distance between both arteries. So such lesion by such distribution and such characteristic widening of the both carotid artery is usually diagnostic or characteristic of the carotid body tumor. This is a right-sided carotid body tumor, intensely enhancing hypervascular lesion at the origin of the carotid space or the origin of the bifurcation of the carotid artery with widening of the both external and the internal carotid artery is a diagnostic for the carotid body tumor, right side carotid body tumor. Okay. This case we can see multiple chest wall collaterals, extensive chest wall collaterals. As we see, this is the internal mammary arteries and this is the intercostal arteries. So this is a hypertrophied chest wall collaterals, and we can see here there is a tight stenosis involving the distal part of the aortic arch just above after the origin of the left subclavian. So all these features are characteristic of aortic coarctation, true aortic coarctation, due to the presence of multiple chest wall collaterals. And aortic coarctation, as there is a tight structure or tight stenosis at a characteristic site, which is usually the beginning of the distal part or the beginning of the descending thoracic aorta, or the distal part of the aortic arch after the origin of the left subclavian. Okay, in this CT enterography case, we can see there is a diffuse submucosal fat infiltration of the descending colon starting from the rectum. We can clearly see there is a submucosal infiltration of the rectum and extend involving the descending colon. We can also clearly see there is a loss of the hostra of the descending colon. These features are characteristic of ulcerative colitis. As we know, the ulcerative colitis should involve the rectum, so it's usually start at the rectum. So if the rectum is spared, this is not ulcerative colitis. There is an infiltration of the rectum, submucosal infiltration of the rectum, and extend proximally. There is no scape lesions, and there is loss of hostra, usually occur in chronic ulcerative colitis, and characteristic of such lesions. And also there is some sort of hypertrophy of the mesorectal fat plane surrounding the rectum. This is one of the characteristics of the ulcerative colitis. The fat plane in the mesorectal space and the mesorectal fascia here is prominent and hypertrophied, and again this is one feature of ulcerative colitis. Okay, this is an MRI shoulder. Show there is a persistent dark T2 signal lesion along the course of the supraspinatus tendon. This is a lesion is dark in T1 and T2 weighted images, likely representing calcification. So this is a supraspinatus calcific tendinitis. Okay, in this case we can clearly see there is a partial empty cella ballooning of the cell and flattening of the pituitary gland against the cellular floor, and there is some sort of attenuation, characteristic attenuation of the distal part of the transverse sinuses. This is transverse. Now there is a attenuation here, and there is an attenuation of the lateral part of the transverse sinus. Such attenuation in this specific site or in this specific location, which is the lateral part of the transverse sinus, is usually characteristic for the idiopathic intracranial hypertension. In this case, we can clearly see there is a dense calcification, pleural calcification, involving the reflection of the costal reflection of the pleura and also the diaphragmatic reflection of the pleura of the right side, associated with pleural effusions and some sort of lung affection, which is subpleural lines. All these features are representative of asbestosis. There is a calcification in the pleura. The asbestosis is usually do calcification of the pleura, especially involving the diaphragmatic reflection, and it may be associated with pleural effusion, and this is called if there is the only affection of the pleura only, this is called pleural related asbestos pleural related diseases. If there is a lung affection, this is asbestosis. So there is here in this case there is a pleural affection and some sort of lung affection in the form of subpleural line. So this is the case of asbestosis. The calcification is very characteristic. The pleural calcification is very characteristic for to think of asbestos. Okay, in this case we can see there is a rather well-defined lesion at the base of the tongue. These lesions show a homogeneous enhancement here. Such lesion in such location, which is the base of the tongue, you should suspect of the lingual thyroid. As we know, the thyroid usually is developed at the base of the tongue and descend during maturation and during development. So in this lesion, in this patient, we can see this is the ectopic thyroid, and if we see here, there is in the normal anatomical site of the thyroid, there is no thyroid gland at the anatomical site of at the normal anatomical site of the thyroid gland. So this is a ectopic lingual thyroid. This is the thyroid gland here in the tongue and the base of the tongue, and there is no thyroid gland in the anatomical position. So this is the ectopic thyroid gland. Okay, the last case here is there is in this CT post contrast images we can clearly see there is a multiple tortuous vessels smearing the extraaxial CSF spaces. This multiple tortuous hypertrophied vessels, once you see, you should suspect moya disease. This is the CT angiography study confirm the presence of the supracellular stenosis or attenuation of both internal carotid artery. So there is attenuation of the both internal carotid artery here with multiple tortuous collaterals filling the extraaxial CSF spaces. This is a characteristic of the moya disease. Okay, I hope this was a beneficial lecture, and meet you again soon, inshallah.